To introduce first up is Tim Sutton, and Tim is a cardiologist at Middlemore, as well as working in private in the Auckland Heart Group. He's got an interest in heart failure, and he's found that he's diagnosing amyloidosis with increasing frequency over recent years. And he's also spent time at the National Amyloidosis Centre in London, where he's learned a lot about amyloidosis. We've also worked at other places as well.
Okay. So this is how amyloid is generated. So I'm going to talk about TTR amyloid. There's about 60 different types, but really as a cardiologist, the main one I see is the TTR. And all TTR means is it's to transport thyroxine and retinol. So we need it to carry thyroid hormone around our body and vitamin A. So if you get some of the more advanced treatments, you do need vitamin A supplementation. And we all generate TTR amyloid, so we've all got it in our bodies and we need it there. And it's normally this tetramer, so there's 4 proteins all bound together. And along the binding sites, you've got different proteins that will connect with each other. And that's where, if you have a genetic mutation, you have a problem, because the glue that holds your TTR together isn't quite perfect, and it'll start to become unfolded, and then it starts to fold up in a skewy pattern rather than like it should do, and that's when it starts to deposit in the organs in the body. And the wild type TTR, once again, you've got the same process going on, but for some reason the natural glue that holds your TTR together isn't so effective. That tends to occur later in life. And if you take men's hearts, and they've looked at a series of 80-year-olds who've had postmortems, 25% of males will have amyloid in their heart. It may not have caused a problem, but if you look for it under the microscope, it's there. So it's a natural part of the aging process. And with all things in life, there's a sort of a bell curve. So some people get disease at an earlier age. A lot of people, naturally you may find that all males who reach 130 get TTR amyloid. We just don't know because we don't live that long. But it is a natural part of the aging process. But the TTR can also deposit in the nerves, which gives you the peripheral neuropathy with it. It can go to the gut. So if you've got the genetic form, it can deposit in other places. But the wild type TTR, which is the non-genetically determined one, has a tendency to go for tissues. So I guess what I'll talk to you about first is how does a normal heart work? Because I think most of you are not doctors. So to understand how a disease affects the heart, you've got to know how a heart normally works. And these are the phrases that we use. So the heart has got muscle, and that's all a myopathy is. It's a disease of a muscle. And the way our heart works, it's a pump. So everyone in their head can imagine a pump has to squeeze to empty. And that's an easy concept to get your head around, and that's systole. But TTR amyloid tends not to cause systolic dysfunction. The AL amyloid, light chains are actually toxic to heart muscle. So if you have really high light chains, that can affect the function of the heart. And the bit that people don't necessarily appreciate, if you don't prime a pump properly, it won't empty properly. And the analogy I use, rightly or wrongly, is firing a gun or a cannon. If you don't prime a cannon or a gun properly, it won't fire. And that's what the problem is with the heart. So it's diastole, which is the filling of the heart, is where TTR amyloid causes a problem. And in the heart, I guess if you remember back at school, there's 2 chambers. There's the atrium, so that's the collecting chamber, and the ventricle is the pumping chamber. And amyloid can affect both of those, but how a ventricle works, it's normally elastic. So if you imagine you've got a balloon and you pour 50 mils of water into the balloon will expand. You pour 100 mils in, the balloon will get bigger, and when you stop pouring water in, the balloon will squeeze and squirt the water out, and that's how a normal heart works. It's elastic, so you put more volume in it, it contracts to the volume that you've stretched it to. Now, if you've got TTR amyloid, the volume of your heart is restricted because, as I'll talk about in a minute, the amyloid builds up in the muscle. So you can pour 50 mils in and the heart can cope with that. But if you imagine that it's like having a cup, or an egg cup, say I pour 50 mils into an egg cup, it'll be fine. If I put 75 mils into an egg cup, it'll overflow. If I put 75 mils into a balloon, it'll expand and accommodate it. And that is how amyloid affects the heart. So your heart just can't fill as much as it should do. And because the heart's a bit stiffer, your pumping chamber, the atrium, has to squeeze a bit harder. And we'll come back to what that does to you over time. So that's the dynamics of a normal heart. And the other bits of a heart, there, it's organised. So there's the electrical system. So amyloid can build up in the electrical system. It can cause issues with the conducting tissues and abnormalities of the heart rhythm. It can deposit in the heart valves and make the heart valves thicker, and sometimes they don't open properly or they'll leak. Or it can build up in the lining of the heart, and it's not uncommon to see builds up of fluid in the pericardium or a pericardial effusion in people with amyloid. And also it can build up in the blood vessels, not so much with the TTR but with the AL. One of the ways that people present is they have angina, or symptoms like angina, so they get tight in the chest when they walk, but their heart arteries are widely patent. So they've had an angiogram, their troponin test, which is a heart muscle protein, is slightly elevated, and they say, oh, there's nothing wrong with your heart. But it's actually the heart arteries have trouble with the microcirculation, so it can cause symptoms that way. So how does TTR affect the heart? It's what we call a deposition disease. So if you think about heart muscle, hopefully I've got a picture of it here we go. So heart muscle is these sheets, and they all interlock, and heart muscle works by contracting. So you just get these fibres that overlap. And this is what normal heart muscle looks like. Now, ignore the fibroblast thing, this came from an article talking about both. But what happens is the amyloid builds up in the spaces between your muscles called the interstitial space. And what that does is your heart muscle gets spread out, so it just can't shorten as effectively as it should do. Now, it can still maintain the output of the heart, but it just can't increase it as much, so the cardiac output will drop off, but the ejection fraction often stays preserved. And over time, you can see the muscle gradually gets spread out as more TTR sort of deposits over the years. Cool. Yeah, and it affects the heart, the ventricle more than the atrium. So the atrium can get TTR in it, but there's not a lot of muscle in your atrium, but the ventricle is a big chunky thing. And interestingly, TTR amyloid causes more thickening of the heart than AL will. So AL tends to present earlier in its deposition because it's more toxic for the heart. Sorry about this. Here we go. I'll whiz through that. Cool. Great. Cool. If we go forward again. Yeah, so like I say, so in systole, the squeezing function, amyloid will impact on the ability of the heart to squeeze, but usually the ejection fraction, which is one of the measures we use, is preserved. But you may have read ultrasound reports or doctor's reports, and it talks about LV strain, and that's the way the heart thickens and shortens. So you can maintain your ejection fraction, which is how much blood you squirt out, but the strain is disrupted. But really what it does is it reduces elasticity of the heart, and that's the whole business about filling. You can only get so much blood in. And as time passes, the heart gets stiffer, causing more symptoms of breathlessness. And that's more of an issue when you walk, because when you walk, your heart goes faster and your heart has less time to fill. And that's why people get breathless with amyloid. And gradually the pressures go up, and that predisposes to fluid retention, basically. I'll cook with that. Here we go. So how do we diagnose TTR amyloid? Well, as Nazar said, it often takes a little while to be picked up. It's what we call the index of suspicion. So you've got to think about it. And I guess as a cardiologist who sees people with heart failure, it does come across my mind when I see people with heart failure. But what are the things we think of? There's this business of a preserved EF. So that's people who present with symptoms of heart failure, so they get breathless or they get swollen, they may get abdominal distension. But the heart works normally when we measure it by ejection fraction. And if you look at a population with heart failure with a preserved EF, about 15% of males will have TTR amyloid as the cause. So it's being under-recognised. Often what used to happen, I guess if you went 10 or 15 years ago, the problem was we had no treatments. We didn't have good investigations and say the heart's a bit thick, you've got heart failure with preserved EF, this is how we treat it. But we didn't go looking more for the cause. People have had non-cardiac symptoms. Now, I'm suspecting the vast majority of your TTR amyloid that's wild type have had carpal tunnel syndrome. That happens about 5 to 10 years before you actually present with your cardiac symptoms. And 10% of people who have carpal tunnel syndrome release, which is the little tendons in the wrist, actually have amyloid TTR amyloid in their carpal tunnels. People can present with spinal stenosis, so the TTR can build up in the lining of the spinal cord and cause symptoms in the legs. And I don't know how many of you have got biceps muscle ruptures. It makes you look like Popeye. So what will happen is you get a ping in the arm and the bicep suddenly looks super buff, basically. But what's happened is the amyloid is built up in the tendon and it'll snap. So I can see a few of you showing off there. So, but it's something that, it's under-recognised, but when you see it, that's quite obvious. The other thing is if people have high blood pressure makes your heart thicken. Now, as a rule, as we get older, all our blood pressures go up. But some people with amyloid, because the heart is a bit stiffer and not working so well, your blood pressure actually comes down because you can't generate high blood pressure anymore. So someone who you see with heart failure, who's previously had high blood pressure and starts to need less medication, you've got to have going through your mind, could it be amyloid? And of course there's the family history, because some people will have genetically determined TTR amyloid. And then we do examination looking for signs of venous congestion, so that's swelling can be in the abdomen. We look at the veins in the neck, we listen for the murmurs, listen to the lungs. And it's important to check the postural drop as well, for reasons I'll come back, because often people feel dizzy when they stand up, especially if you've got nerve involvement, because you get what's called an autonomic neuropathy, and that's the system that controls our day-to-day functions, like the bowels, the heart rate, your breathing. It's not something you have control of, but when it gets affected, it causes all sorts of mayhem that you may not realise will occur. And then we get on to doing investigations, like Nazar said. We do an ECG, hopefully. We do blood tests first, we do cardiac biomarkers. Those are the troponin T and BNP. The troponin is a heart muscle protein, and that gets released when the heart's unhappy for a whole group of reasons. The commonest one is a heart attack. But not every elevation of the troponin is a heart attack, but it's often how the pathway is set off. And BNP is essentially a hormone produced when the heart's under stress, and the more stressed you are, the more you produce. So if the BNP is high, it's a marker of how the heart's coping. We check on the kidney function, because that gives you an idea of what might lie ahead in the future. We check on the albumin, that gives you an idea of how nutritional status is. Because if you're not getting enough energy in, when you have heart failure, you burn off energy, this will drop down. And like Nazar said, these are the tests we do, ruling out AL amyloidosis. And then we'll go on and do an ECG, hopefully. So the ECG as a cardiologist is our basic test, which hopefully we'll see. And what we look for on an ECG, normally when a heart is thick or hypertrophied, the ECG has a typical pattern and the complexes on the ECG are big. But with amyloid, there's not hypertrophy, there's replacement. So if you see an ECG as a doctor, that you've got an echo that says a thick heart and an ECG that doesn't say a thick heart, that should raise the index of suspicion that someone has TTR amyloid. And often you'll see change over time. We can see patterns that suggest someone might have had a heart attack before. We can see the heart can be going slower. So there's a whole heap of things you can see on the ECG. And change is the important thing as well. And as a cardiologist, our other, here we go, oops, can you go back one? Our other go-to investigation is an echo. Hopefully it'll play. So like Nazar showed you, if you read there's this LV strain plot with a cherry on top or apical sparing, and that's because amyloid typically builds up and affects more the base of the heart than the apex of the heart. And if you look at this bit is the apex and it's squeezing more than the base of the heart, and that's all we're seeing on this thing. It just shows that the speed at which the heart's moving, and it moves better at the apex than the base. The other things we can see on echo, you can see the thickness of the heart function. We measure heart elasticity, we can look at the heart valves, we can look at pressures inside the lungs, and that all gives us useful information about thinking what's going on and what may lie ahead in the future. And with serial echoes, you can assess people's response to treatment as well. And then once you've got someone who you've got a suspicion they may have TTR amyloid, this was really a game changer in terms of enhancing diagnosis. So a DPD scan, initially they used to be done for people with cancer, and you were looking for metastases, or people with arthritis looking for infected joints. But what people started to see was there was this tracer uptake in the heart. And then someone said, oh, wait a minute, we've got someone with uptake in the heart who's breathless and they've got a thick heart. And that's how DPD scans grew from being something that's used primarily looking for bony disease to something that as a cardiologist we use to look for TTR amyloid. And there's different phases. There's grade 1, which is where the heart doesn't look too impressive and the bones take up more, but the heart takes up a little. There's grade 2, that's the heart there. But the heart and the bones are pretty similar. In a grade 3 one, you can see the heart takes up most of the tracer and the rest of the body doesn't take up so much. These are the kidneys and bladder, that's the other bits you see there. But the DPD scan is now the go-to test. So if someone has a thick heart, you've got a suspicion of amyloid, this is the test you should do. But what used to happen, if we went back 10 years ago, MRI was taking off. And we used MRI when people had thick hearts, looking for scarring in the heart as part of a condition called hypertrophic cardiomyopathy. And that's really how I started to see amyloid, because you'd suddenly get this result saying the patient had amyloid. And the DPD scans were only available through the private sector in New Zealand Medical Imaging, but now we can get them done in Auckland, so there's much easier access, and we're doing them a lot more. And the guys at Auckland are just looking at their outcomes. MRI produces beautiful pictures, and it's a very good way of assessing heart muscle tissue. And what you can see is there's lots of expansion of the extracellular volume, and that's because you've got that deposition. It spreads out. The heart muscle and the extracellular volume figures go up, which is here, so normal's down around 30. So MRI is a useful tool, but not the main one, and really you don't need an MRI to diagnose TTR amyloid. And the guys in the Amyloid Centre, combined with the guys in the US, have come up with this pathway to help us diagnose TTR without actually doing a biopsy if we can. So essentially, as we've talked about, if you've got symptoms, an ECG or an echo, and if you've even had an MRI, then you can make sure there's not excess light chains. And about 30% of people will have an abnormal blood test for this, and it takes us down a different pathway. Bone scintigraphy has suddenly become so much more widely available. If the bone scan is abnormal, you've got no light chains, you have ATTR amyloid. So it saves people having a biopsy of some tissue. And from a cardiac perspective, really the biopsy you need is heart. If you've had a biopsy from another site, then you can always get that looked at for amyloid and assessed, like Nazar talked about. But really we want to get heart tissue if there's light chains. And if you've been told you've got ATTR amyloid, you must have gene testing, because the question is whether it's wild type. So if you use an individual, that's important, but you can't pass it on to your family, or whether you've got a genetically determined type. Now, the incidence of the genetically determined TTR amyloid in the population is about 1 in 50,000. But as I've talked about, the wild type is much more common. So in the heart failure population, it's about 15%, and people with narrowed heart valves, aortic stenosis, 15 or 20% of them will have, or 15 or 20% of males will have TTR amyloid as well. Patients who've been told they've got hypertrophic cardiomyopathy, just thick heart muscle, about 5% of them actually have TTR amyloid. So it's out there, and because DPD scans are being done more, it's being picked up more easily, basically. And I'm sure over time we'll see more people being diagnosed. If you have a biopsy and it gets its mass spectrometry done and it's abnormal, you go down this pathway, but if the mass spectrometry is negative, then you should be looking at other causes. And the DPD scan has about 90-95% sensitivity and specificity. In other words, it's pretty accurate, basically. And that's the pathway we should be going down, and it saves having a biopsy, which to me is usually a good thing. So the gene testing, like I say, it either tells you don't have a gene or you do. There's about 120 genes that have been shown to cause TTR amyloid. There's some that present with more neurological symptoms, and there's some that present with more cardiac type symptoms. Now the commonest one, I guess, on a global level is this one here, which is the valine 122-isoleucine. So that produces a change where your amyloid tends to unfold. It's not something we see in New Zealand, but this is common in people from the African subcontinent. So in the UK and in America, it's blood flows. If they present heart failure with thick heart, it's the first thing we think. And about 3% of the population actually carry that gene from Africa. This one is the valine 30 I can't remember what the M means, methionine mutation, that tends to present earlier. That's the Portuguese variant. This is a slightly different group than everyone else because they respond really well to liver transplant. And the others are sort of in the middle. There's a T60, this one here, is an Irish variant. So you can map where your genetic history comes from by if you carry the gene, because the genes come from different parts of the world. There's a Scandinavian one as well, which I can't remember. But like I say, at a global level, this will be the most common one. At an English level, at a New Zealand level, genetic variations are uncommon. Next one. But it is important to get the gene testing done. And then if you do carry a gene, you link into a genetic counselling service. Because testing for having a genetic test, for those of you that have had it, if you know you carry the gene, then it links you into a pathway for the future. If you don't carry the gene, it's great, but that's where genetic counselling is really important. And this gives you an idea of why there's been a delay in diagnosis. So if you look at what testings we've got, orthopaedic surgeons, with all due respect, expecting them to think about amyloid not necessarily at the front of their radar. But that's often where they present first. And they present, like I said, with these sort of things. But then we often start up here, and you can see this is where the disease is at its most progressed. And this is where the disease is beginning, down here. If you could do a biopsy of tissue, but obviously you can't biopsy everyone, you can do these fancy tests, PET scans. This fluke beta pair here, that if you have that in your heart, it's really sensitive for TTR amyloid and AL amyloid. But the problem is you need a cyclotron, which generates the contrast that they use. So this is available only in small numbers at the moment. DPD scans have only more recently become available, and this is probably in New Zealand the earliest we can pick it up. But this is where we've been before. So the diseases are often presenting when things are quite advanced. And what we need to do is shift it this way, so you can pick people up earlier, because the earlier you treat people, as I'll talk about, the better the response you get. But this just shows you here, it can take up to 3 years for people to be diagnosed, just because of this, and access to these. Like where I work out in Middlemore, it can take a year to get an echo. But there's a year to delay to diagnosis. So trying to get around these things is a challenge. Cool. And this is why, this is the impact DPD scans have had. So this is data from the Amyloid Centre in London. So this is when I started as a cardiologist. You can see mainly the people that were seen with the others, which is the ALs, and there was people with genetic disease. MRI came out 2005, and suddenly we were doing MRIs and finding more people had amyloid who didn't have hypertrophic cardiomyopathy. Then DPD scans suddenly took off in 2010, which was about the first time I went to the Amyloid Centre, and you can see suddenly there's this exponential increase almost in diagnosis of wild-type TTR amyloid, and that's a function of the DPD scan. So that's when it suddenly took off as a diagnostic technique, and that's something that's just going to keep on going up and up. And one of the problems, as I'll come to in terms of drug treatments, is that this is a rare disease. This is not. When we think about what happens with amyloid, like we were talking about, this is where the disease is starting, and before it gets identified. At the moment, this is where we tend to pick things up. The natriuretic peptides are going up, the troponin is going up, the kidney function may be getting a bit worse. Usually the ejection fraction is preserved, but people start to get breathless. And ideally we want to pick people up at this, where things are early on. And these stages here where we use the BNP and renal function. So if your BNP and renal function is good, then you're in stage 1. If your BNP and renal function is not so good, you're in stage 3. And ideally, as you see, what treatment options? Talk about heart failure first of all. So what treatment options do we have? The one proven drug for TTR amyloid is tafamidis. When I read this, I thought it was the ATTRACT study, but then it's actually the ATTR ACT study, because I heard the authors have to get access to treatment. You had to have proven TTR amyloid, and people were given either 20 or 80 milligrams of tafamidis. And for the first year, there wasn't much change, but after 18 months, the group on the placebo, the sugar pills, started to experience more events, and those events were trips to hospital, but also the death rate started to increase, or you could say that tafamidis was preventing people from dying. And if we go out to 3 years, tafamidis reduced the death rate by about 10%. So that's a huge change over 3 years. And if you look at this, these are ways we look at, you say to yourself, okay, these are different groups. Which is better, the sugar pill or the active drug? And you can see here, people who are class 1 and class 2, so they're people who are less symptomatic, they're a little bit breathless, they got a huge benefit of being treated. But if you start to become more significant breathless, and class 3 means you can walk about half a K before you get breathless, the tafamidis didn't make too much difference. So it's really important if we're going to be starting treatment to start it early. It didn't make too much difference. The wild type people did better. There were less of the genetically determined ones. So the message from this is tafamidis works. It's best to start it early in that disease pathway I showed you, so when people are minimally or mildly symptomatic. Now, the problem with tafamidis, as one or two of you in the room may be able to attest to, it's prohibitively expensive. It costs $400 for one 20 milligram pill. In this trial, they're getting 80 milligrams. So that's $1,600 a day if you're going to be taking. And that's what it costs in the US as well. So that's the major challenge. And as I mentioned, cost is driven by rareness of a disease. If you have a rare disease, the drug company can charge the earth for it. Once a disease is recognised as not being rare, the cost has to come down. And as I showed you from that slide from the Amyloid Centre, this is not a rare disease. There are a lot of people who have TTR amyloid who will benefit from the treatment, but the problem is at the moment it's still called a rare disease. But this is what's changing at the moment in terms of international perceptions, and hopefully we'll see the price of tafamidis come down at some point. And this is the busiest slide, and I guess one of the more important ones. What else is out there? So, like we talked about, the liver makes your TTR amyloid, and to make anything, you need DNA. And as we talked about, some people carry an abnormality in the DNA, so if you can stop the DNA working or interrupt the way it works, and that's what the RNA silencers do, you can stop yourself producing TTR amyloid, and then it won't go on and cause disease. So these are the RNA silencers, and these are patisiran and inotersen. They've been shown to work with peripheral neuropathy. When the trials have looked at people with heart disease who were in the study for peripheral neuropathy, it looks like the drugs worked, but they've not been proven as yet in patients with TTR cardiomyopathy, but there's trials going on that are enrolling at the moment, or they've completed enrollment, so we'll know about that in the next 2 to 3 years. And if you think tafamidis is expensive, it's cheap compared to these. These are about $500,000 US a year. So cost is a major, major issue. Anything that has RNA silencer in it, it's going to cost the earth. This one's an infusion that you have to have every 3 weeks. This one's an injection that's once a month. There's another one called patisiran, which has come out that we were trying to get in a trial, but unfortunately post-COVID sort of enrollment suddenly expanded and costs were a bit too great at our end, I think. There's your tafamidis here. Another agent, we've actually done a trial with this one, is acoramidis, is another TTR stabilizer. So one or two of you may be in the trial looking at that, which is the ATTRibute trial, which hopefully will be released in about a year or two. My observation is it does seem to work. Diflunisal is an anti-inflammatory. So it used to be around 40, 50 years ago called Dolomid, but the earlier generation anti-inflammatories were withdrawn from the market because they tend to cause more issues with kidney upset and bleeding in the gut. However, diflunisal is quite potent at stabilising TTR amyloid. It's actually got approval in Europe for peripheral neuropathy, and it's been used in a trial, but from a cardiac perspective, it's not been put into a trial to see if it works as yet. But it's got off-label approval in Europe to be used for cardiomyopathy, but not in the US. I was reading something on the way here that's suggesting that this is something that gene carriers could actually take because the side effect profile is low enough that if it stops disease progression, it may be a way to go. But these are things that all need exploration and proof, because we like to be able to say we know this works, rather than we think this works. But diflunisal is available here through a pharmacist, and you can get hold of it. You just need a friendly pharmacist who won't fleece you too much for the processing costs, because it's not on the New Zealand formulary. As a cardiologist, we tend to worry about drugs that cause fluid retention, because they can make heart failure worse. And often people are on blood thinners as well, so you've got an increased risk of bleeding. Other things that are available, there's doxycycline and TUDCA. So doxycycline for AL cardiomyopathy actually protects against things going wrong when you're getting your chemotherapy. It has a protective effect on the AL light chains on the heart muscle. So it's now given routinely with chemo for AL amyloidosis. But there's a trial going on at the moment looking to see whether doxycycline and TUDCA help clearance of the TTR amyloid from the heart muscle tissue. But as yet, it's not been proven, and the side effect profile is reasonably high. And then there's another thing here, we've got the green tea, because they didn't have green tea in this one. So that's what this is, EGCG, which I can never remember exactly what it means. But it's the active component of green tea extract. The therapeutic dose of this is about 400 to 600 milligrams a day. It's something essentially you purchase online, it's not prescribable, but you need 400 to 600 milligrams of the EGCG, so it's a concentrated green tea that is the best thing. It can affect the liver function. Now, green tea extract's not being used in a trial as a drug. No one's going to fork out the money to actually see if this works, but it's been used in an MRI study, and the patients treated with the green tea extract, the heart muscle got thick less quickly than people who weren't on it, basically. And at the end. So treatment options are general. We encourage everyone to exercise. If you've got any cardiac condition, exercise is important. Building up muscle strength, independent of everything else, improves your sense of well-being. We keep an eye on fluid intake. As I said, the heart it can't get over full, it just can't get rid of the fluid. So we try and encourage people to limit their fluid to around 1.5 litres. Obviously, if you're tiny, that's probably going to be a bit too much. For your average person, that's okay. And limiting salt intake is much more important. Salt makes you thirsty. If you're taking lots of salt, you drink more. And if you drink more, you swell more. So we try and keep people under 3 grams a day. And general cardiac strategies, they're similar to what Nazar was talking about. We give medications. We're trying to keep people as volume, euvolemic, so at as steady volume as possible. We use the water pills, diuretics, and the best one I believe is bumetanide. Frusemide is the one that's more commonly used, but the problem with frusemide is anyone who takes it will tell you that if you start to swell up, it doesn't work so well. And the problem is frusemide levels can vary between 5 and 80% in your body from a tablet. So as you get more swollen, the amount of frusemide in your blood drops off. You take more, you get more swollen, you go to hospital, and the junior doctor say, "Are you taking your frusemide?" You say, "Yes." And they say, "Are you sure? Why are you putting on weight?" So, bioavailability, you fool, didn't you, at a medical school? But bumetanide has about a much more stable bioavailability. So if you do start to get a bit more congested, you take an extra one, it works better. So it's a better drug to use. Like I say, that conversation about frusemide I have encountered more than once. We use aldosterone receptor antagonists, that's spironolactone. That helps keep potassium in the body. We use it in other people with heart failure with preserved EF. But the important thing is to avoid drugs that may make you worse. So that's steroids for your gout, anti-inflammatories, apart from diflunisal, but we know that may cause problem. We want to avoid agents that drop the blood pressure. So treatment for high blood pressure can cause issues, and these are things like ACE inhibitors or amlodipine. They relax the blood vessels, and the problem is you can't increase your heart output very much if your blood pressure drops. And that means it causes problems with postural hypotension or dizziness. And some medications actually bind to the amyloid fibrils. So a drug like diltiazem or verapamil, they can actually, if you take a pill, it'll go and bind to all your heart protein, heart muscle, and it can cause problems with heart block, or actually can cause shock by impairing the way the heart works. Drugs like beta blockers as well. Your heart, when you exercise, should speed up, and that's how you increase cardiac output. So your cardiac output is simply your stroke volume, which is the amount you squirt out with each beat, multiplied by your heart rate. Now your stroke volume, as I've said, there's only so much blood you can get in the heart amyloid. So if you limit the speed of your heart by a medication, your problem is you can only get so much blood out. So if you take drugs like beta blockers, often people feel worse because you can't increase your cardiac output to as much you need for your body to keep happy. So that's why we try and avoid those drugs if possible. And what else can pop up over the years? You can get irregular rhythms like atrial fibrillation. That happens in about 50% of people with TTR amyloid. It's really important if you have AF to be on blood thinners to protect against stroke, because the risk of that happening is high. And we have to decide whether to keep the heart under control with rhythm pills, but for the reasons I mentioned, they can cause issues, or whether we try and keep the heart regular with a pill called amiodarone, and that is the best drug to use. People can also faint, and that can be because the heart goes too slowly as the amyloid builds up in the heart tissues. It can be because the heart's going too fast, or because the efficiency of the heart's been affected because the blood pressure's low, and that can be heart function, or because of the medications that we give, basically. And if you do have faints, then you often put pacemakers in. And what may arise over the years, we're trying to get clinical trials up and running. As I said, unfortunately the patisiran was closed, but we're in touch with drug companies trying to get other trials. And at the moment we're trying to get an Auckland Regional Cardiac Amyloid Clinic established, because I don't know if you guys know how DHBs work, but essentially they're not very keen on doctors from one place going to another, or patients from one place going to a different DHB. But hopefully with the way things are moving, with there being no longer being DHBs, we'll be able to work at a more regional level, and that means more collaboration at doctor level. And also for patients, it means if Dr. A, DHB A, knows about condition Z, you can go and see them, or you should be able to go and see them without people saying, well, hang on a sec, they're not in your DHB, we're not paying for you to go and see them. So hopefully, I may be dreaming, but hopefully those sort of things will happen. But we're actually trying to get a centrally located regional amyloid clinic where we can try and see people from initially around the Auckland region and Northland, but hopefully around the country. And by doing that, sort of we can link in with the patient support group as well and enhance people's care, and also get access to more clinical trials as well. And you'll have heard Simon talk last night, but he and I have been in touch about tacking into the Australian Amyloid Network as well. I'm not sure they're going to call it the Australia and New Zealand Amyloid Network, it may be the 7th or 8th state or whatever it is, from Australia in that viewpoint, but that'll be cool to join in as well.
I take it from what you say that while the causes are completely different sort of the effect on the heart of TTR and AL is essentially the same.
Yeah, it's pretty similar. So the amyloid is what you see under the microscope. So you've got the same thing, you've got that by different processes. The AL, as Nazar said, tends to, it's produced by bone marrow, so it's really building up quickly. TTR is slower, and the light chains you produce are toxic to the heart muscle as well. So that's why it presents a bit more aggressively. So the heart muscle tends to be less thickened for the degree of symptoms you have, but also the heart function tends to be a bit lower as well. Therefore, when people with AL amyloid get treated, they often, you can get a very good response in terms of symptoms, and much better than you ever see with TTR amyloid, because TTR is taking years to build up. AL will build up over a year or two. So it's a much more aggressive process.
So I think that a lot of people, from what I understand, who are diagnosed certainly with AL cardiac, the first go-round is you've got athlete's heart. What is athlete's heart?
Well, athlete's heart is, so if you're an athlete, the way you adjust to, all these guys who are supreme sports people, their resting heart rates are in the 30s or 40s. And so they have the ability to increase cardiac output hugely. And as I said, your cardiac output is your stroke volume multiplied by your heart rate. Now, an athlete needs the same cardiac output at rest as your average punter with a heart rate of 60. So with a heart rate of 40, the only way it does it is by having a bigger stroke volume, and that just means the heart's bigger. And that's what an athlete's heart is. So they have a dilated heart, so the chambers are bigger, the heart muscle is often a bit thicker as well, depending upon the type of exercise you do. So if you do like cycling, rowing, they often have slightly thickened hearts as well, and that's an athlete's heart. But when you do LV strain on athletes, it's usually supranormal. So there's subtleties on echo that will tell you, this looks like an athlete's heart. So there's all guidelines that give us an idea of what we should be looking for. And when you put someone on a treadmill, of course, they respond normally. But a heart, for someone with amyloid, they'll get pumped, and the pressures inside the heart go up.
We have problems with sore nerve endings, particularly in the feet. Can you explain why that's happen?
I'm going to do a whole talk about
We've got a neurologist to talk about
in a minute.
Can you have two types of amyloid? Because there seems to be a big crossover of symptoms.
That's where the biopsy is important. So if you remember that pathway shown, so you can have TTR amyloid, and that is by far the commonest thing people have. But yeah, you can have AL and TTR amyloid. That's why you have to have a biopsy. So if your light chains are normal, you won't have AL amyloid. If your light chains are abnormal, you might have AL, you might have TTR, and that's why a biopsy is important. And you never say never in medicine. Some unfortunate people are going to have both, but that's where the biopsy is so important. I've not encountered anyone who's clearly had both, but once again, you don't see that many people with it. But that's where the biopsy is so important. It's more important so you don't give chemotherapy to someone with TTR amyloid, and that's if you go back 20 years, there's actually a report in the Medical and Young Journal about that, about how important it is to actually type the amyloid, because it used to be you saw light chains, you saw myeloma, you saw a thick heart, therefore this is amyloid, therefore you need chemotherapy, and you know that can accidentally cause harm. So that's why the biopsy is so important.
But you know, you can get the carpal tunnel, the breathlessness and neuropathy, the pain in the joints and everything, back pain and everything with ATT, as well as AL?
Oh, AL can affect anything. Yeah, so AL builds up absolutely anywhere. Interestingly, things often improve with chemotherapy. People often improve substantially in terms of all their symptoms. That, you know, we don't see AL amyloid very often as from a cardiac perspective. It's about 1 in 100,000 people get it. But the people I've seen who responded to the treatment, a lot of their symptoms disappear. It's absolutely amazing. Their heart function improves. They feel a lot better. The neuropathic symptoms have improved as well. I saw one patient who couldn't put her hands together in our claws, and they suddenly, all the amyloid disappeared over time. So that the amyloid does disappear from your body if you have AL. And they've done studies in London looking on MRI, and you can see that cardiac amyloid improves over time as well.
And if your condition gets worse, even though you've had chemo, you know, like neuropathy, neuropathy maybe?
Oh, yeah. I think from my understanding from the hematological side of things, I mean, when I was a medical student, and I guess if you go, I don't know if you've got AL, if you go on the internet, I'd advise you against going on the internet to look up anything, because it's full of doom and gloom. And the average survival with AL amyloid, when I was first learning about it, was 3 months. So essentially, if you told someone they've got AL cardiac amyloidosis, it was a death sentence. The treatments that the hematologists have come out with over the years have made a huge difference there. And the average survival has now been pushed out to, I think 50 or 60% of people will survive at least 5 years. And you get your Cyberdex chemo, your early stuff, and then there's a whole new generation of drugs that have come out. So they've got about 5 levels of treatment for bone marrow disorders. And in the US, the FDA just approved a drug called daratumumab purely for AL amyloidosis. Now, when I was over there, they were just starting to use it. Once again, new drug, rare condition, prohibitively expensive, $500,000 US a year. But the guy, the hematologist I was talking to about it, said the response you get is absolutely stunning. It just completely switches off light chain production. So that's something that hopefully over time we'll start to see becoming available. I don't know if it's available here, but there are options in here. And, for the AL, there's multiple levels of treatment that can be considered. People live 5, 10, 15 years now with AL amyloid. ups and downs, but it's so much better than the 3 months 25 years ago.
Thank you, Tim.